lah.
Hmm?
So I will present the case, and then throughout I will ask you some questions, or they will ask you some questions, something like that
Ah,
lah. Yeah.
okay. All right.
Okay.
Sure.
So I started recording.
Mm-hmm.
So just a general guideline. Everyone, please raise your hand. Use the raise hand function before asking any questions. And until then, please unmute yourself before I call on you. We will record the session and post it on the Facebook page. So just follow there for future updates. The recorded session will also be made available in this Teams group. I will put it in the Files tab lah, as usual. Please spare some of your time to fill out the feedback form. It will take about 2 minutes of your time. Okay, so today we are very honored to have Dr. Loh Thian Chee with us, UMMC. How do I say?
I'm a
Uh,
respiratory fellow.
okay, respiratory fellow. She has taken a few supervising teams before, I think, medical students.
Yep.
Yeah, so she's very experienced lah, I say, quite experienced in teaching us this kind of things. So so doctor, do you like to introduce yourself first?
Yep. So I'm Dr. Loh Thian Chee. I'm currently in the respiratory unit, University Malaya Medical Center. So this is my second year of training, being a fellow. I've actually taken medical students in UM for I think 2 to 3 years now. This is how long I've been in UM. Mainly general medicine, but of course, being a respiratory trainee, I have more experience and knowledge in terms of respiratory medicine. So I can share a little bit more with you guys. So, like for example, today's case by case basic session is about someone with respiratory problem. So hopefully today I can share a little bit more with you guys. Okay, back to you, Hailiang.
Okay, thank you, doctor. So this next slide. Next slide. Okay, so maybe just a little bit of warm up on the whole thing. So this is the diagram that I've gotten from Kumar and Clark. This is the types of respiratory failure. Doctor, can you elaborate a little bit on the types of respiratory failure?
Okay. So before I elaborate, so I would expect all of you to know there are actually two types of respiratory failure lah. Okay, so it's actually type 1 and type 2. Okay, so let me ask you one question. How do you differentiate type 1 and type 2 respiratory failure from arterial blood gas? Anyone?
You all can just type in a group chat. Okay, Edward Fu, you want to say something?
Mm-hmm.
The presence of hypercapnia is suggestive of type 2.
Yes, so it's basically a raise in PCO2. Okay, so whether the pH is normal or not, it doesn't matter. But in type 2 respiratory failure, you would have a high PCO2 and a low PO2. Okay, so in type 1 respiratory failure, you have low PO2, but you've got low PCO2 or normal PCO2. Okay, so good. So you've really had a very good understanding. So type 1 and type 2 respiratory failure is a blood gas diagnosis. Okay, so you probably all those type 2 respiratory failure CO2 retention signs might not be present in clinically in the patient. Okay, so you cannot rule out type 1 or type 2 respiratory failure clinically. It's just like stroke. Okay, so when you see a patient with unilateral body weakness and then blood pressure systolic of 240, you cannot say, this is definitely hemorrhagic stroke rather than ischemic stroke. No. Okay, although it's more suggestive, but hemorrhagic stroke or ischemic stroke is a diagnosis from CT. So just like respiratory, okay, it's a diagnosis from blood gas. So type 1 respiratory failure, it's mainly failure of oxygenation. Okay, so you have to think from the top to the bottom. So how does oxygen get into our body? Okay, so gas would go into our body via our nasal or oral cavity. Okay, then to our oral nasal or laryngopharynx, trachea, and then only go to our smaller airways and to lung parenchyma. So any of these places that have problem would cause hypoxemia. Okay, failure the gas to be delivered to our system. But type 2 respiratory failure, as you all correctly pointed out, is a buildup of carbon dioxide. meaning that there's some failure in our system, in our respiratory system, that leads us to fail to excrete CO2. So how our body excretes CO2 is by exhalation, correct? So it's a ventilation failure. So it's your failure to ventilate and to wash the CO2 out. Okay, so mainly type 2 respiratory failure has got something to do with obstructive ventilatory defect or your inability of your breathing mechanics. So for example, your chest wall deformities, neuromuscular weakness, central apnea, or something like that. Okay.
So, doctor, I've read in Kumar and Clark, right? It says that the most common cause of respiratory failure is COPD. Would you agree with that?
I wouldn't say so.
Mhm.
I wouldn't say so because I think any type of lung diseases, especially chronic lung diseases, can potentially cause respiratory failure.
Mhm.
Okay, so I wouldn't say when you see someone with a respiratory failure, first thing first, you must consider COPD. Because I think, the way we learn medicine is that the most common cause for so and so is so and so. So it actually, it's trying to train our brain to think that common things happen commonly. So don't go dig the very uncommon, the very rare diagnosis to explain why your patient presented that way. Okay,
Mhm.
so probably you in respiratory, anything can cause respiratory failure, whether type 1 or type 2. So it really based on your history, physical examination, and other investigations to support what is the most likely, what you call that, respiratory failure in your patient. When I do on call, the most common type of respiratory failure is because of pneumonia.
Mm.
Acute lah, I mean acute, right?
Yeah.
Second, followed by acute pulmonary edema because of heart failure or fluid
Mm.
overload because of kidney failure.
Mhm.
Right? It really depends on your history and so on.
I
Okay?
see.
Mm,
Okay, I think if there's no more questions, we can go on to the prompt.
sure.
Okay, so I'll just read the prompt real quick. Okay, so
Mhm.
Mr. Lee, a 59-year-old male present with underlying COPD, presented to the hospital with a 3-day history of shortness of breath. So, anything you'd like to add, doctor?
Mm, I think that's good.
Okay. Okay, so I'll just read the presenting complaint. So the presenting complaint is, of course, again, shortness of breath, a 3-day history which is sudden in onset, persistent in nature, and progressively worsening in severity. It is exacerbated by exertion and lying supine and flat, and it's relieved by rest and sitting upright. It's not relieved by using his inhaler given to him 3 years ago, and his activity of daily living has been affected so much so that he can only walk very slowly without having to stop, and is associated with a left-sided chest pain. So, doctor, anything you'd like to add here?
Mm, Instead of me wanted to add, I would
Mm-hmm.
like to ask any of you wanted to add anything or ask anything else.
Anybody? So, doctor, like I like to ask you about. Oh yeah, okay. Chun Ying has something to add. Yeah, but doctor,
Mm,
about the exacerbating factors and the relieving factor, right?
mm.
So it's exacerbated by lying supine, while relieved by sitting or standing upright. Um, would this count as autopnea or not really?
I would say yes,
Hmm.
because orthopnea means your shortness of breath exacerbated or brought up upon lying flat, isn't it? I would
Mm-hmm.
say
Yeah.
this is orthopnea. Yes, you're right.
I see. But from what I've read is that autopnea is not directly, it's not the only, no. Uh, Heart failure is not the only cause for autopnea. Would that be correct?
Correct. Correct.
Mm-hmm.
Okay.
So
You
we
see,
cannot just, yeah.
yeah. You see, you have to really think of why patient get orthopnea when lying flat. What is the pathophysiology?
Anybody wants to try and answer?
Mm.
Increased venous return.
Increased venous return. Yes. Then subsequently leading to
Anybody want to try? Nobody want to try. So,
Come on, guys.
pulmonary edema.
I think,
Shiva Jyoti said.
yeah, I think at this point, right? I mean, you guys are students, all right? You better get it wrong now or get it wrong later, okay? Because you guys are training, it's normal to get it wrong, okay? If you get everything right, you won't be a student anymore, so you'll be a doctor and probably professor by now. So it's normal to get it wrong, okay? I always consider my colleagues who are so superb and knows everything are abnormal. So I always consider myself as normal because there will be things that I don't know. There will be things that are gonna make fun of myself in front of everyone. But I mean, I suppose it's always good to ask now when you really got no more time to ask when you're a houseman, when you're busy working, and at the same time you still need to sit for exam to further your subspecialization. Okay, be more interactive. Okay, so what Hai Liang said, yes. Okay, so you have, when you lie down, you don't have the gravity pull anymore, isn't it? So you got all your blood trying to return to the right side of the heart. So when it goes to the right side of the heart, where else will it go? It'll go to the pulmonary vessel, isn't it? Pulmonary artery and out. Okay, so it will increase suddenly a lot of blood returning back to your heart, and you call pulmonary congestion, and that's when you get the shortness of breath. Okay, so anything that leads to increased pulmonary congestion, anything is wrong with your right side of your heart, with your lungs, will actually demonstrate autopnea.
I see.
Not only heart failure.
Tia Chingwen asked, could it be due to reduced perfusion also?
Reduced perfusion, as in reduced perfusion to the lung or what?
I think that that should be the case. Yeah.
Okay, so probably you're thinking of cases like PE. Okay, something is obstructive, so reduce perfusion to the lungs. Then if you have something blocking, you try to give more fluid to that pathway, but the pathway is blocked, then of course you will get more symptoms. Yes.
So right now, viewing this presenting complaint, just the presenting complaint lah, not the associated everything else. Is there anything, any diagnosis that would come to your mind with the underlying and this kind of presentation?
So you're asking me or you're asking your colleagues?
I'm asking you first lah. See what you say first.
Okay, so it's good to generate differential diagnosis very early on. Okay, because even in the first slide, the 50 plus years old with COPD, come with shortness of breath. So at that point of time, you should be generating differential diagnosis already. I always tell this to my student because you want to keep your differential diagnosis as wide as possible. And then when you take history, then only you narrow down those differential diagnosis, which one is likely and which one is unlikely. Because once you have your brain stick to one diagnosis, you don't have differential diagnosis, that's when you get into trouble in exam and also in real life. Okay, so now we've got further information, got more information now. His shortness of breath has been there for 3 days, but it was sudden onset. Okay, it wasn't gradual. So at this point, I would think of something quite sudden, like PE, pneumothorax, or cardiac cause, like MI or arrhythmia. Okay?
Yeah.
Right? And then it's persistent, progressively worsening. So whatever is going on is probably worsening. Okay, exacerbated by exertion and lying supine and flat. So that's autopnea and exertion. So these two things, more. Okay, and also of course exacerbated by exertion, of course you're going to relieve by rest. Okay, if exacerbated by lying supine, then when the patient sit upright, you get better. Not relieved by using his inhaler. So that would go a little bit against exacerbation of COPD. Okay. Usually exacerbation of COPD will be more gradual in onset. Okay. And usually will be partially relieved by inhaler. No matter how poor the inhaler technique is, if some of the bronchodilator is going into the lungs, you will be partially relieved. Okay. Probably not ACOPD. Okay. Affected daily life. Okay, that's a very good thing to ask because you want to know how much he's able to do and how much he can do now. Okay, and then you give a very important point now. He has some chest pain as well.
Yeah.
So left-sided chest pain, what can it be? Cardiac. Okay. So again, goes towards acute coronary syndrome, arrhythmia. Okay. Or left-sided chest pain can be left-sided pneumothorax, can be PE also. Okay. So these are the things that will go towards that field diagnosis at this point.
Yeah.
Okay. So we probably need further information.
Okay.
Any other thoughts from other people? Any other
Uh,
differentials?
yeah, Shahira Shuhada said pneumonia or congestive heart failure.
Okay, pneumonia. Then we will ask further lah. That's why I said we need further questions. We need further information whether he's got productive cough and things like that. Yes, I agree. Pneumonia can also cause chest pain, pleuritic chest pain, irritation of the pleura. Good one. Okay, congestive heart failure, not so commonly will cause chest pain. Okay, and usually heart failure, unless it's an AMI. A decompensated heart failure usually more gradual, whatever triggered the heart failure. Okay, so you guys have to remember, heart failure, decompensated heart failure is not the full diagnosis. You have to tell me decompensated heart failure secondary to what? Okay, a compensated heart failure will suddenly become decompensated has been due to something. Okay, so if you're thinking of CCF, a decompensated heart failure, you have to probably think of what will make the heart failure suddenly get worse. Usually it's acute coronary syndrome and also arrhythmia.
Okay, so I think that's all. We can just move on. Okay, so for the chest pain, right? So it's a 3-day history also. It occurred together with the shortness of breath with a severity of 5 out of 10. It's a sharp pain on the left side of the chest with no radiation anywhere else. It's exacerbated by taking a deep breath, causing him to take only short breaths in order to avoid pain. The pain is persistent but not increasing in severity over the 3 days. Otherwise, no cough, no fever, no upper respiratory tract infection symptoms, no palpitation, no weakness, no muscle weakness, no loss of weight, no loss of appetite, no history of chest trauma, no proximal nocturnal dyspnea. So from the chest pain, right, doctor, this exacerbating factor, I think it's quite clear that it's a pleuritic chest pain.
Correct.
So a pleuritic chest pain with what you call that, the shortness of breath with such a history, does it make you think of anything other than the differential diagnosis that we've already considered?
Okay, if you ask me, I would like to ask a few more questions regarding the chest pain.
Okay.
Okay, is this the first time you had that kind of chest pain?
Yes, the first time.
First time. Never had left-sided chest pain before?
No.
Okay. So, okay, the chest pain occurred together with the shortness of breath.
Yeah.
Okay. So that you are trying to tell me that the chest pain was also sudden onset.
Yes, sudden too.
Okay. All right. So if the patient able to tell you, is the chest pain comes first, then right after that SOB, or SOB come first, then right after that chest pain?
I don't think it's very clear lah. That one not that clear.
Okay. So sometimes if the patient can tell you, then you will probably able to tell the chest pain is actually the culprit that leads to the shortness of breath, not because the shortness of breath leads to the chest pain. Okay, so if you say, I suddenly got this left-sided chest pain, then after that straight away I feel. So
Doctor, you're breaking off.
Hello. Hello.
Yeah. Okay, can.
Can connection here very bad lah. I use university connection somehow. Are you?
Oh, okay.
So until where? Until
you were saying the chest pain before the shortness of breath.
correct. You have like if the I got this left very suddenly. After that, I get shortness of breath. Then you know the diagnosis is probably related to the chest pain rather than the shortness of breath. The shortness of chest pain. Okay. about the chest pain?
Yeah, doctor, you're breaking off again.
Ayo, can hear? Ah?
It's like
Hello.
it's like a 3 second thing lah.
Oh no. Okay.
But now okay lah. I don't know why just now.
Oh dear. Because it was quite well then for the past 15 minutes. My God.
Yeah.
Okay. So yeah, what else I need to ask you? Let me think. Okay. Exacerbated by taking deep breath.
Mm-hmm.
Okay. So what relieved the chest pain?
Not really any relieving factor for him lah.
So the chest pain is just there,
Yeah, it's
but
just there.
if it takes deep breath, it becomes worse.
Yeah.
So he was never pain-free.
No.
So for these 3 days, never pain-free.
No.
Okay. When he was, the severity is 5 out of 10. Am I right?
Mm-hmm. Yeah.
So if he takes deep breath, what will be the pain score?
Oh, yeah, that one I didn't ask lah. But it should be worse lah. It should be worse.
Yeah, it should be worse, but how much worse?
Not that sure lah. Hypothetically, let's say 8 out of 10.
Okay. All right. So let's say if this is a cardiac pain, let's say
Mm-hmm.
so a 3 days worth of 5 out of 10 chest pain, likely or not, if this is cardiac?
No, not really.
Not very likely. Okay.
Mm-hmm.
If someone who suffers from ischemia with this kind of pain for 3 days, I don't think he'll be alive by now.
Yeah.
Okay. And go. And if the pain doesn't go away, by 1 day, patient will come to the hospital because it's going to be quite bad.
Mm-hmm.
Okay, so this is probably going to tell me that this is less likely cardiac cause. Probably acute coronary syndrome, less likely.
Mm-hmm.
Okay, so anyone has any other questions for chest pain?
Anybody can just type in the chat.
Yep.
Or is this enough to come up with a list of differential diagnosis? Because you see, there's no fever, no cough, so you rule out pneumonia. The shortness of breath also don't sound like a acute exacerbation of COPD, so
Correct.
that one also ruled out. No palpitation, so not arrhythmia, not really the cardiac cause.
Yeah, someone said bilateral lower limb swelling. Has it got lower limb swelling?
Oh yeah, no, sorry, I didn't put that in.
Okay. Autopnia, but lower limb swelling.
Huh? What?
So got or PND swelling. Oh, can you hear me?
Yeah, you broke off a bit just
I'm
now.
breaking off again.
Yeah.
Aiyo. Okay, never mind. If we break off again, I'll try another type of internet connection. But it's
alright.
okay. Okay.
You were saying what again? The
Okay, I
autopnia
was
thing?
saying that he's got autopnia. Okay,
Uh-huh.
but he doesn't have PND. He doesn't have lower limb swelling. Okay. So heart failure still can, but not very likely. All right. So
Yeah.
if you can put that as a differential diagnosis, but probably a little bit way down now. Okay.
Okay.
So what else I wanted to ask? URTI symptoms, upper respiratory tract infection symptoms. What are those actually?
So rhinorrhea,
Mm.
sneezing.
Mm.
What else? Rhinorrhea, blocked nose.
But your upper anything
Oh, hello.
anything
A bit breaking off, but a lot of people are saying sore throat.
sore throat? Yes, good. Anything else?
Anybody else want to try?
Anosmia. Anosmia. Yes, can, but not what I'm looking for. Nasal discharge can. What about hoarseness of voice or loss of voice?
Yeah.
Okay, so pharyngitis, laryngitis. Okay, facial pressure, yes. Sinusitis, right? You get facial pain. Okay, good. I just want to make sure that you know what is URTI symptoms because sometimes even my MO doesn't know it. Okay. All right, we can go on, I think.
Okay. So for the miscellaneous history, just a little bit on the past medical history. His COPD was diagnosed 3 years ago. It was diagnosed in the hospital in Penang after a lung function test and a chest X-ray. It initially presented with an increasingly productive cough for the 2 years prior to the diagnosis. After diagnosis, he was nebulized and later discharged with an inhaler, which he used 3 times a day. He, on normal days, he is able to walk up 2 flights of stairs, but will be short of breath after climbing those stairs. Otherwise, no history of exacerbation during the 3 years prior to this current admission. Past surgical history is not is insignificant. He uses Barodual, which is ipratropium plus phenterol. Sorry, this is Saba plus Sama, not Laba. Sorry, inhaler. Allergic history, no known food or drug allergy, and family history. He has no significant history of asthma or other malignancies.
Okay. Any other question you wanted to ask?
Anybody? Anybody want to try? So based on the previous differentials,
Okay, let me ask. So diagnosed 3 years prior to admission. This admission you mean?
yeah, this admission.
Okay. Any CT scan done?
No, not mentioned.
You know why? Anybody know why?
Why there was no CT scan or
Why I asked for a CT scan?
Oh, okay. Anybody?
Are you
Bronchiectasis. Excellent. Sherwin. Why are
Just
we
now, yeah.
suspecting bronchiectasis?
Anybody wants to try and answer?
Sherwin, if you want to explain yourself.
I think because of the COPD exacerbation, then and the sputum also can cause dilation of the bronchial tree.
Yeah, it's more of, okay, COPD can present with cough, okay, but it doesn't typically come with productive cough, okay. COPD patient will come with dry cough or very just scanty sputum, all right. So when you have productive cough, first thing I would think of probably is bronchiectasis. So whether he's got concomitant COPD and bronchiectasis, okay. Yes, excellent. And I don't know why is he treated with only Sama, even though he presented with, presented to a major hospital. Any reason why?
That one I don't know.
Not too sure.
Not sure. Not
Okay.
sure.
Right. Okay. So did you ask him, have he ever tried other inhalers?
Doctor, you're breaking off.
Hello?
Yeah, no.
No, Okay. All right. So, okay, this is a question to the floor. Able to walk up 2 flights of stairs. So that's MMRC what?
Anybody want to try MMRC?
Are you familiar?
Everyone is Google searching or what?
Google lah. Better Google now than Google later.
Anybody want to try MMRC? This is a what grade?
This is MMRC what?
Regine said grade 2.
Grade 2. Okay. What is grade 2?
Regine, you want to
Less
answer?
than peers.
But he's going up on a slope, right? If he climbs
Yeah.
stairs. So have we asked him how is he do it on a level ground?
Level ground. No, I didn't ask. Should it be asked, doctor?
Because you see, when he climbed flight of stairs, he said, I can climb 2 flights, but I get short of breath. It sounds more like a MMRC 1 to me. Okay, but even at the, if it's in the level ground, then when you walk with your peers, they're slower than probably MMRC 2.
I see. So should always grade it not just the lower base level, then enough, we don't need to continue asking, is it?
You probably can ask what is the maximum he can do and what's the without getting what I mean.
No, you're breaking off. Cannot hear.
Sorry. Can you
Yeah.
hear now?
Yeah, now can.
Okay. So you probably need to get what he can do. What is the maximum he can do without getting symptoms?
I see.
If you know what I mean, right? So he said if kalau uncle mandi tak apa, kalau pakai baju tak apa, kalau jalan pergi kedai pun okey. Jalan dengan kawan-kawan semua pergi kedai tak ada masalah. Tapi kalau panjat tangga semput, then actually on the flat ground can walk. Okay, but go up the stairs probably not too bad. He can still go 2 flights, but after 2 flights he gets short of breath.
I see.
All right. No history. 3 years. Okay. So if you are now, now what do you think the goal stage?
Cannot hear you, doctor. You're breaking off again.
What do you think is the goal stage?
Oh, for this patient?
Him now.
Huh? What?
If you are now.
No, cannot hear. It's a bit.
Hold on. See if I can try changing my.
Okay. In the meantime, anyone wants to ask any more questions?
Okay.
Okay.
Can you hear me?
Yeah, can doctor.
Okay. So the goal classification.
For this patient.
Correct.
Is A, I think. By right lah, because no history of exacerbation that led to any admission, then able to walk up 2 flights of stairs, so should be MMRC grade 1.
1?
Yeah, so A, I would think.
Okay. So no exacerbation means not even using the MDI at home. Their apa ni sama at home. Because exacerbation in COPD does not mean admission only,
Yeah.
So if he's got no admission, but he's got history of nebulization at home or in the GP, or taking his Berodual few times a day because he gets short of breath, that one is exacerbation as well.
Okay. So that nebulized thing and the third line, is it considered an exacerbation or that's just initial presentation?
Okay, let's say if you see him now and there hasn't had that admission to hospital Penang, hasn't had nebulization before, he's just a bit short of breath. He noticed that he's not as active anymore. Last time can climb 5 flights of stairs, but now only 2 flights. Okay, if he presented to you like that, probably you can say 8. Okay, but he is already exacerbating, like going to the clinics for nebulization, admitted to hospital Penang, then my diagnosis will be probably go C. Okay, although he's not very symptomatic, he still can climb flight of stairs.
I see.
Goal classification is only important during diagnosis because you want to know what kind of medication to initiate. Okay, because subsequently all the follow-ups, your goal classification doesn't matter anymore. All right. Okay, let's go on.
Okay. So just a little bit on the social history. The patient lives with his wife and 4 kids in an apartment on the 19th floor in Penang. with adequate facilities, for example, lift and gym and swimming pool. However, he seldom does any exercise at home and rather spends his time watching TV. He worked as a cook for 40 years, and he retired 3 years ago due to the diagnosis. During his work, he uses charcoal instead of gas to cook at work. Deny use of protective equipment or face masks during work. Smoking history-wise, he smoked 1 pack of cigarettes per day for 40 years until he smoked. Until he stopped 3 years ago. Alcohol use also similar, 1 tin of beer every day for 10 years. Also stopped 3 years ago.
Okay.
So this all actually points towards the COPD thing lah.
Correct. Correct. He's got the risk factors, right? He's got charcoal exposure for 40 years, no proper PPE. He's also, you know, an active smoker, 40 pack years. Okay. Any history of asthma?
No history of asthma.
No. Okay. Because sometimes patient can tell you, oh, everything started 3 years ago. But sometimes they have childhood asthma, which quite transient, and they grow out of it and they kind of forgotten about it. Okay, so after all this exposure, okay, maybe their asthma comes back, or it can be an asthma COPD overlap. Okay, don't worry too much about echo, but it's just something for you to think about because treatment can be different. Okay. Anyone else want to ask any other questions? Okay, I think we're good to go.
Yeah, all right. So these are the physical examination findings. Upon general inspection, the patient is alert, conscious, and responsive. Is in obvious respiratory distress and slightly cachexic. Currently using a face mask with an oxygen flow of 3 liters. I think I put 4 liters in the slide I sent you. That one wrong. And able to talk in short sentences. His vital signs: pulse rate is 108 beats per minute, respiratory rate 30 breaths per minute, blood pressure 134 to 80 over 88 millimeter mercury, pain score 5 out of 10 with SpO2 of 94%.
SpO2 94.
So the SpO2 is on the oxygen.
Yeah, it's on the oxygen.
Okay, all right.
So looking at this, it's actually quite bad, isn't it, doctor?
So how do you describe this patient? Okay, this patient GCS is full, but he's in respiratory distress, tachypneic, tachycardic, and hypoxic. Okay, so otherwise BP still stable without support. Okay, so these are very important. Okay, so sometimes when we're so tired, we cannot listen to numbers anymore, right? When we're on call, all right. So you have to call up your specialist or you call up your MO. I've got a gentleman here, which I think this diagnosis, he's currently still alert, GCS still full, but it's very tachypneic, respiratory 30, hypoxic, tachycardic, BP unsupported. Okay, just paint a general picture. Okay, you said in obvious respiratory distress. So apart from being tachypneic, what else you observe in him?
Oh, you mean the intercostal, the
Correct. Accessory muscles, intercostal muscles. Just to be more detailed. What else you notice? Do you notice those?
Yeah. Yes. The what's that? Sternocleidomastoid use and the intercostal.
So barrel chested?
Barrel chested, actually, actually that's one of my questions. So doctor, how actually do we evaluate whether a patient is barrel chested or not?
The best thing is look from the side, and you will actually see this how to say increase in AP diameter.
So do we need to measure it, or because from what I Google search, it says the chest X-ray shows, but don't know how the physical finding how.
Yeah, chest X-ray hyperinflation is the different criteria to look for in the chest X-ray, but clinically you can see actually the chest increase in AP diameter if you look from the side. It's bulging front.
I see.
Because it shouldn't bulge, right? Your sternum is flat, and your ribs are flat as well. It shouldn't bulge front.
I see. And from what I read also is that barrel chest can also present in middle-aged men with osteoporosis, I think.
That is probably the defect of the spine rather than the hyperinflation of the lungs.
Mm-hmm.
Mm. But very rare lah. I've never seen an osteoporosis with a narrow chest.
Yeah, probably.
More COPD. Yeah.
I see. Okay.
Then go on.
Okay, so for the peripheral examination, no finger clubbing noted, no peripheral cyanosis. The palms are cold, peeled, and dry, with no flapping tremor, no collapsing pulse, no radial delay. Conjunctival erythema noted. Otherwise, no sandalasma, no arcus finalis. Mucous membrane wet, no central cyanosis, no tracheal deviation or raised JVP. However, tracheal tugging noted on deep inspiration. So, again, Doctor, the tracheal tugging, is it a very important sign to look out for?
To be honest, I don't think so.
No lah, not that important.
If you ask me, if you miss that in the examination, I probably won't penalize you.
Okay.
Okay. Don't worry too much. Yep.
All right. So can we move on, Doctor?
Yep.
Or do you...
Yep. Anyone
Okay.
else who have any questions? Good
Lisa
question. What's the
yeah.
significance of radial delay? I actually wanted to ask, but I was like, never mind lah.
That one, it's like you know, because you want to do the cardio and the respi examination, so just check lah. No harm in checking, so I just put it there.
Okay.
Okay. Is there any significance? No, right, Doctor? Not really.
To be honest, depends on your differential diagnosis. What do you want to rule out at this point of time is what you want to look for during the examination.
I see.
Okay, if you think it's more of a respiratory cause, because radial delay is to see what?
Coarctation of the aorta.
Okay. Would that cause this presentation?
No. Sorry, the aortic dissection, I think. Is it?
So
forgot already.
So
Regine said, yeah, subclavian stenosis.
Yeah.
So
you would you see, patient with stenosis present with this kind of presentation? Probably not, right?
Yeah, no.
Yeah. Okay. Depends on what you want to look for. Okay.
So we can
go
just move on. Respiratory examination. So on respiratory inspection of the chest, there's no obvious deformity of the chest wall, no obvious wound or scar seen. Chest expansion slightly reduced on the left side of the chest, not right side, left side. Vocal fremitus reduced on the left lower zone. On auscultation of the chest, vesicular breath sounds heard on the left. Sorry, vesicular breath sounds heard on the right side of
when
the chest.
I read, I was like,
Yeah, a bit weird. Sorry. Vesicular breath sound heard on the right side of the chest with core crepitation heard at the base, with reduced breath sounds on the left side and absent breath sound at the base. With on percussion, it's the way hyperresonant on lung bases
the left
bilaterally.
side. Oh, bilaterally. Okay.
Yeah.
So you think it's hyperresonant bilaterally compared to the upper zones, or what?
What you call that? So yeah, something like that lah. But the left side will be a bit more hyperresonant.
Okay, so you mean that when you percuss the left and right side on the upper and middle zone is a normal resonant, and then as you go down to the bases, it's more hyperresonant compared to the upper and middle zone, but very hyperresonant at the left lower zone.
Yeah.
Okay. All right. So yeah, because of all your typos, I think you give your friend some time to digest this.
yeah. Sorry.
All right. Chest expansion reduce on the left side. Reduce vocal fremitus. Isn't it increase?
Increase.
That lower zone. Okay. But the vesicular breath sound and crepitation at the right side.
Yeah.
The left side is actually reduced breath sound at the upper and middle zone, and then absent at the lower zone. It's hyperresonant at the left lower zone. Okay, just make things simple. It's just hyperresonant and left lower zone. Okay, so everybody got that? Okay, can generate something already in your brain? Why the lung sounds like that? Okay. Okay, I think we can move on.
Okay, so lastly would be the okay, this one never mind. So lastly for the physical examination, cardiovascular examination, on inspection there's no raised JVP even after eliciting the hepatojugular reflex. Reflex. On palpation, the apex speed is deviated, felt on the 6th intercostal space, in between the imid-clavicular line and the anterior axillary line. No obvious trails over the 4 valves. On auscultation, dual heart sounds heard with a faint third heart sound loudest at the mitral area. Otherwise, no added heart sounds or carotid bruit. Yeah, done. So liver edge not palpable, liver downers lost, and no pitting edema.
Okay. Any other questions?
I think that is all. Anyone else wants to add? Ask anything?
Is everyone happy?
If not, we can move on to trying to Yep. So okay, just on summary lah. Here also typo. Sorry about that. It's very confusing also. Okay, so Mr. Lee is a 59-year-old male with underlying COPD, presenting to the hospital with a 3-day history of dyspnea and associated left-sided chest pain. On physical examination, reduced focus parameters and hyperresonant. So long this one. Absent breath sounds heard on the right lower zone of the left. Absent breath sounds on the left lower zone of the chest can be heard. So, is it clear? Is it clear, or you guys confused?
If you're confused, I don't blame you. Please voice out if you still can't get the sign. Or is everyone okay?
If okay, we can move on to the
Yeah,
differential.
if okay, we move on, huh? All right.
Okay. Confused, Okay. Sorry. Okay.
Felicia is confused.
Let me reiterate. So on the left side, on auscultation, there is a reduced breath sound generally and absent on the lower zone, left lower zone. Vocal parameters also on the left. The hyperresonant percussion also on the left. What else? Reduced chest expansion also on the left. Okay, right side is just cause crepitation at the lower zone. The right. Okay? Can not, Felicia? Okay, Okay, So left got problem,
Okay, everything's on the left. The right base is only some crepitation, that's all.
Yeah. Okay, so anyone want to try provisional diagnosis?
Correct. It's the best part.
Okay, can anyone? Okay, so Lao Kai Xiang. Oh, okay, it's just what I repeat. Okay. Anyone wants to try? What do you think is the provisional diagnosis for this patient? With the history and the physical examination findings. Anyone wants to try? Okay, yes, Edward.
Sort of thinking of a left pleural effusion.
Left pleural effusion. The percussion is hyperresonant. You want to try and justify your answer?
Yeah, no. I got a bit confused with the signs.
Okay.
Just
sorry.
now, but yeah, no. I'll have to mull it over again. Thanks.
Okay.
Never mind. Take some time. Respiratory can be confusing. Take some time.
Okay, so Tan Sin Hien said left-sided pneumothorax. And Shahida also said pneumothorax, but noted the cause crepitation. What is his temperature? Oh, I didn't put. It's not febrile. Forgot to put. Edward, you want to say something, or is that just left over. Okay, so pneumothorax, doctor, is it a good provisional diagnosis or is it not that good?
Yes, pneumothorax is good. That would be my first my first provisional diagnosis if I were to see this patient.
I see. So COPD, does it lead to anything pneumothorax?
Yes, definitely. COPD can lead to pneumothorax. We'll talk about that a bit later.
All right. Li Feng asks, can the pleural effusion be mild due to the barrel chest?
Okay.
What's that?
So resonance is mainly you compare left and right? Okay. So barrel chest would be bilateral, isn't it? Have you seen a unilateral barrel chest, like left side is barrel and right side is not? No, right?
No.
Okay. But then now the clinical finding for this patient is actually hyperresonant on the left base. And we assume the right base is normal. Okay. So if you got a fusion on the left lower zone, okay, so what would be your percussion? Dull or resonant? Dull.
Dull.
Right? Okay. And Regine said stony dull. Yeah, that's what I wanted. Effusion is typically stony dull. Okay, because consolidation can be dull also, right?
Yep.
Okay. So you see, barrel chest, right? It's because of increase in lung volume, correct? Your lung is so hyperinflated. Okay. So as your lung volume increase, your chest wall somehow has to increase as well in volume. Okay. But if anything is present in the pleural space, it doesn't matter. Because whatever you're percussing, the first thing you percuss will on the water, isn't it? It makes sense? I mean, you can imagine that or not? Because it will be your chest wall, the effusion, and then the lung. So whatever you're percussing will be on the fluid, which is going to be stony dull. Okay?
Yep.
So effusion will be dull. Okay? If it's hyperresonant, it can only mean few things. Okay? It's either a pneumothorax or there's a bulle sitting there.
Which could be the case also because bullous emphysema or something.
Correct. So the cause of this, if it's ever a pneumothorax, most likely is one of the bulle that ruptured. Okay. So again, a CT thorax in the past would be helpful if he had ever had one. Okay, maybe he has got multiple bulles everywhere. One of it is actually ruptured. Okay, any other diagnosis?
Anyone wants to try? Just now we mentioned a few things, right, that could cause this thing.
Yeah, we mentioned a few things. What was our initial provisional diagnosis, when we said short of breath, sudden onset for 3 days? What were we thinking? PE.
Okay.
Yes. Still possible, although the clinical findings actually points towards almost one diagnosis. But let's say if the hyperresonant and the reduced breath sound in the left lower zone is actually a bulle, which is not the cause of the problem, then PE is likely. Still have to think of PE also. Good. Anything else?
Anybody else? Pneumonia. Shahira said.
Shahira said pneumonia due to cause crepitation. The cause crepitation is on the right side, but his chest pain is on the left side. Okay, usually the site of pneumonia is the site of pain. Okay, but yes, you actually, you further describe your diagnosis, say, but it's against it because hyperresonant on the left side, so a bit less likely. Okay, good. Anything else?
Secondary.
Cannot question mark. Infection. Bronchiectasis doesn't really cause pneumothorax. But I agree that the right crepitation can be because of infection or can be because of bronchiectasis because it's caused crepitation, isn't it?
Yeah.
Okay. But I think we all agree that the pathology is on the left side now. But of course, the right side need further workup later on. Yeah.
Okay, so I think we have our provisional and our differentials. Anybody else wants to add anything else? So just to summarize, our provisional would be a pneumothorax. Differential would be pulmonary embolism, pneumonia, and what else? Acute exacerbation of COPD. Is that fair, doctor? Do you think it's not that correct or?
Yep. That's good. But one thing I wanted to ask, why is the apex speed displaced?
Not sure.
Have you thought of
that...
it?
Oh yeah, I don't want to answer. I think we let them answer. Anyone wants to try?
Let's let them answer.
Why is the heart enlarged? Cor pulmonale. Can it be the cause, doctor?
Right. Cor pulmonale, is it dilatation of the left heart or dilatation of the right heart?
Right heart. I hope the answer. Right heart.
Right. But now apex is more of the left atrium. Correct? So how why the apex speed displaced?
Massive pneumothorax causing mediastinal shift, but trachea is not deviated. Shifa said.
Good, Shifa. Good. Very good. I was actually thinking it's actually a mediastinal shift. Okay. That's why I was quite surprised that the trachea was not deviated. But sometimes a collapse of a lower lobe, left lower lobe, can be large enough to pull the lower mediastinal structures, but the trachea remain central. Okay, but good thought. Very good. I think it's because of the pneumothorax.
Okay.
Another thing is if it's cor pulmonale, usually you hear some tricuspid regurgitation.
And the JVP might be raised also.
Might be raised, yes. Okay, but the first thing I think we'll notice is a TR.
Oh, the
Before
TR will be first.
The TR will be heard, rather than your right ventricular heave and your raised JVP. Before that, I think you'll hear a TR. Okay, let's move on.
All right. These are the investigations. This investigation, I'm not sure correct or not lah, because I don't have the actual investigations. I just put.
So you just made it up.
Yeah, kind of.
Okay.
I just made it up lah, but
Alright.
hoping that it's okay, should be correct lah. I hope. So full blood count is normal. Renal function test is 5.1 milli equal EQ per liter. ABG pH is 7.33. PaO2 76 millimeter mercury. PaCO2 is 53 millimeter mercury, and the bicarb is 33 milli EQ per liter. Coagulation profile normal, plasma D-dimer normal. Peak flow velocimetry and spirometry is just suggestion to do. So these are the following things are the things that I suggest. I'm just putting here for a thought experiment. So from the ABG, I think it's quite clear that this is type 2. But do you think this is proportionate to the patient's condition? Since we already discussed the whole thing.
Okay. To interpret a blood gas, okay, we of course look at the pH first. 7.33 is acidosis. Okay. Then we look at the CO2 and the bicarb. So this is the respiratory acidosis. What do you think about the bicarb? Low, normal, high?
Anybody want to try?
High. Excellent.
Yeah.
Okay. So what does this mean? compensation. All right. I would say partial compensation. All right. Partial metabolic compensation, or patient actually had acute or chronic CO2 retention. You know why? Because the pH is not normal. If it's full compensation, meaning that patient is having chronic CO2 retention, your body will work in such a way that to normalize the pH. Okay, whatever CO2 bicarb, whatever it is in your body will try to make sure that these two will balance out to give you a normal pH. Okay, in the normal situation. So if this guy is walking in front of you, seeing you in the clinic, looks quite well, PCO2 of 53, the bicarb should be higher to bring the pH to normal, because 7.33 is acidotic. Okay, so in this case, when we've got the high CO2, a highish bicarb, but the pH has not been normalized yet. So only two situations. One, the high CO2 is acute, body is still partially compensating. Okay, pH hasn't gone back to normal yet. Or patient actually now had acute or chronic CO2 retention, meaning that in normal situation, his CO2 is not that high. It's high, but it's not that high. So meaning that the CO2 will be a little bit lower to match that bicarb for a normal pH. So now when he's unwell, he's got more CO2 retention, then suddenly your body hasn't managed to catch up. That's why your pH dropped a little bit. Okay now, okay until now or not? Can understand or not? People who cannot understand, please post it in the chat group or anything like that. It's very important. Understand so far? No one post anything? Understood. Okay, good. All right. But looking at this patient, he's currently unwell. He's got, COPD for 3 years, probably not very well treated. He probably has chronic CO2 retention with metabolic compensation, but because of this acute illness, he decompensates a bit, so it becomes acute on chronic CO2 retention. Okay, he is hypoxic. Okay, PaO2 is only 76 on 3 liters of oxygen. Even with supplement of oxygen, he's hypoxic. Okay. So I don't usually do peak flow and spiral when patient is unwell. If you want to know how bad they are, I probably do on the day of discharge, near discharge, or at my outpatient clinic, because it probably won't change my management much now. It's quite clear it's COPD, right? Quite clear it's COPD. So what you get a spiral now, the FEV1 over FVC is less than 0.7. Doesn't change anything, right? Yeah. You still treat him as a COPD. Okay, but asthma is different. Asthma peak flow monitoring is very important. Okay, because for asthma, they can be as normal as a normal person, or they can be as bad as go to intubation. All right, so you need to monitor their peak flow, whether they have improved with your treatment or they continue to deteriorate. That's very important because they have a normal lung. Okay, remember, they have normal lung structurally. But COPD, structurally, their lung is bad. Okay, chest X-ray is very important. CD thorax, plus minus, depends on what you see on the chest X-ray, whether it's adequate or not for you to make a diagnosis and for you to do treatment. ECG, yes. Okay, at his age, COPD, smoker, do an ECG. Okay, echo a bit later to check for cor pulmonale. Yes, agree with you. And a VQ scan if you ever suspect PE. But nowadays, not many people do VQ scan because it's not widely available. And we've got the luxury of doing CTPA to roll up PE. Okay, but his D dimer is negative and his pre-test probability is low, and you see a huge pneumothorax on the left side, probably no need. Okay. Move on.
So this is the imaging that I took from Radiopedia. The case is also similar, left-sided pneumothorax. So so I think if you strain a bit, you can see the pneumothorax.
I squint until I cannot see, my eyes also cannot see.
I don't know, maybe it's a bit small, but the whole screen thing can actually see that line of that little bit of demarcation.
No.
But
Where is the
yeah, a bit got lah. At the left, that middle got got missing
I think
what's
the
that called? Lung
periphery, I mean
marking.
the left lower zone periphery, there's absence of lung marking lah. That's what I saw. But the actual pleural line
Yeah, a bit
can't really
difficult.
see lah. But I hope you all know how a pneumothorax looks like on the chest X-ray. Please. Okay.
Okay. So the CT scan, the axial scan is on the left lah. If you want, you can go and check the radiopedia lah for those who are interested. It's just there. You just type COPD check case, I think 14 or 15. Yeah, it's
Okay.
there.
See if I can get some images in a real patient, and then I'll post it in the what you call that? Our
The group.
Microsoft Team. Both
Alright.
CT and what you call that, chest X-ray imaging. See if I can find some. Try post it tonight or tomorrow.
Okay. Okay. Thank you, doctor.
Mhm.
So just the last few slides. Let's just go a bit quicker. So this is the list of monitoring equipment that we can use for people with respiratory failure. So pulse oximetry, blood gas, PaO2, FiO2 ratio. Doctor, do we need to do this for this patient?
PF ratio, I only do it when I suspect acute lung injury and ARDS. Okay, because your PF ratio is 100, 200, 300 cutoff point. So that will tell me how bad the ARDS is. I would suggest you do AA gradient as well. Have you heard of AA gradient? Yeah.
Yeah.
So a normal, a normal hypoxic AA gradient and a high hypoxic AA gradient give you differential diagnosis, different differential diagnosis. Okay, you can go and read about it.
Okay. Capno, no lah, not really lah.
Capnography not available, not widely available in all center. ICU has it. Okay, and our sleep lab has it. Those who do polysomnography. So we got a cutaneous CO2, so we can monitor the CO2 without doing a blood gas. It's like a pulse oximeter. You just stick it. That thing you can just stick it on your finger or stick it on your forehead, and then they will tell how much CO2. Very convenient, but very expensive machine.
All right. Okay. So last. So this is the management that we did. Oxygen treatment is I added one. Other than that, it's all the same. Chest tube is inserted into the left side of the chest, and then they monitor for the chest tube drainage container for any blood or anything like that. Monitor for shortness of breath and chest X-ray for resolution of pneumothorax. Advised to buy incentive spirometer and to use regularly at home. Consider the change medication. So doctor, just now you mentioned that you will put this patient as a grade C COPD
Gold
patient.
C.
Yeah, gold C.
Okay.
So yeah, this is
he's now on just a short acting inhaler, right? And he uses it quite frequently, isn't it?
Yeah.
So it looks like he's quite symptomatic, to be honest. He use it quite a bit because I think he exacerbates. Okay, so let's say he's gold C. Okay, you know your gold guideline, right?
Yeah, I know lah.
It's gold 2020 now. Throw away on 2019. Okay, go read the 2020. If you're not graduating by this year, look forward to 2021. They always change.
Okay.
So, but I think the principle of treatment is still the same. Okay. So let's say you see this patient first time, you diagnose COPD, gold C. What would you give? Anyone?
Anyone wants to try? So definitely not ipratropium lah. I already mentioned it's sama, right? So that one is out. Anyone wants to try? Long-acting muscarinic antagonist.
Some long-acting lah, huh? You don't want short-acting to be the mainstay of treatment, of course. You want something more longer-acting. Okay, short-acting is only for those without much symptoms, doesn't exacerbate. Just use it PRN. Okay, that's why only group A we will give a short-acting bronchodilator. Even group B and above, we will give something long-acting. Okay, so group B and group C, the difference is in group B, they got lots of symptoms, but very rarely exacerbate. Okay, but for group C, they can tell you they got no symptoms, but you see them in the ward every month. Okay, so for all the COPD clinical trials, we have noted that long-acting muscarinic antagonists are better in terms of reducing exacerbation. So that's why you see people in group C, they got lots of exacerbation. So they'll benefit more from LAMA rather than a LABA. Okay, but a LAMA and a LABA, both they are very good at reducing symptoms. So for group B who's got lots of symptoms but doesn't exacerbate much, you can either give a LABA or a LAMA. Okay, and group D, of course, those who comes to you, with exacerbation, admission, on high flow oxygen and all these things, you would want to consider dual therapy, either LABA-LAMA or a LABA ICS. So you can see the bintang there, how to choose whether a LABA-LAMA or a LABA ICS. Okay, there are a few criteria to consider. Okay, so in this gentleman, right? So when you auscultate his lung, there's no rhonchi, isn't it?
No.
Any bronchospasm? No.
No.
No. So I think his shortness of breath is mainly because of the pneumothorax rather than COPD exacerbation. Okay, COPD exacerbation usually will come with bronchospasm. Okay, they will come with reduced breath sound, generalized reduced breath sound, generalized rhonchi or wheeze. Okay, so for this patient, we settle the acute problem. Yes, we insert the chest drain, okay, to hopefully re-expand the lung. Okay, but at the end of the day, we want to re-evaluate the lung structure. Okay, this patient will need a high-resolution CT thorax to really look at the lung structure. Okay, whether he got some other bulle sitting somewhere, bronchiectasis, okay, emphysematous lung, that we really need to do. Okay, and then of course to optimize his COPD treatment. Okay.
Okay.
And okay, you said chest tube inserted left side, monitor chest tube drainage. Would you expect lots of fluid coming out?
Not if it's a pneumothorax.
Correct. Okay, so you would expect a little bit of pleural fluid because pleural fluid is being produced in our pleural space every day. Okay.
Yeah.
So you will expect something to come out. Don't expect just dry. You will expect something to come out. Okay, but not a lot. Okay, probably 20, 30 cc a day, right? But you wouldn't expect too much drainage. But what is important for you to monitor in the chest drain for a pneumothorax?
If I'm not sure. Open the floor. Anyone? Any idea?
Any idea? Have you seen a pneumothorax with a chest drain before? Have you actually looked at the chest drain and the bottle?
Yeah.
And did you see what your doctors do every day?
Oh no. No.
Not really.
Not really.
Okay. So the first thing when I ask if someone has a chest tube, whether it's still fluctuating and bubbling. Okay. Why would a chest tube fluctuate? I mean, okay, you see the tube, right? And then the tube will be connected to a underwater seal, correct? There's a bottle with water. And then you will see the level of the water going up, down, correct? Okay, you because that bottle, right? In the middle of the bottle, there's like a plastic tube, a transparent plastic tube. And then the level of the water will go up and down. Okay, so Chunying said inspiration and expiration cause different in pressure. Excellent. So that's what is causing the fluctuation. Okay, so because during inspiration, there is a negative pressure in the thorax. And expiration, positive pressure in the thorax to push the air out. Correct? Okay, so this difference in pressure causing the fluctuation of the water level. And they should fluctuate. Even with a fully expanded lung, they should fluctuate. Otherwise, your chest tube is not functioning. Something wrong somewhere.
Okay.
And why should it bubble? So when you see the patient breathe out, right, and then you see the bubble coming up from the water like that, Have you seen
Uh-huh.
that?
Yeah, that one I
Yeah.
see.
Have you thought why?
Still got air in the
Correct.
pleural
Those are the
cavity.
air in your pleural space.
Mm-hmm.
Right? So every morning, patient with a pneumothorax, how do you know that their lung is fully expanded and you're ready to off the chest tube?
When there's no more bubble coming out.
Correct. Excellent. When the chest tube is still fluctuating but it's no more bubbling. Okay. Takkan you want to shoot patient X-ray every day to see the lung expansion? No, right? Cannot be lah. Right? So you can monitor clinically. You can auscultate the lungs again, whether the air entry has become equal. All right. The air entry has improved. The percussion has improved. Always go back clinically, right? See whether the expansion of the left lower zone has improved. Okay. And then ask him to take few deep breath or even cough and see any more bubbles. If it is no more bubble, do a chest X-ray to reconfirm no more pneumothorax, then you can safely off the chest tube.
Okay.
Okay, so just some extra, what you call that, practical things.
Okay.
Okay. So when you do chest X-ray to confirm the presence or absence of pneumothorax, what order you want to write in the X-ray form? It's also quite practical.
An erect chest X-ray.
Correct. PA erect. What other instruction you want to write there?
Not sure. Open to the floor.
Pandai lah you.
Tuning said fully inhale.
Aha. It's got something to do with inspiration and expiration, but tuning, not correct this time. Not decubitus, it's not the position, PA erect, but it's got something to do with respiration. Okay, when Chunying say inhale, I say incorrect. So means is what?
Exhale lah.
Exhale lah. Why you want to do it in expiration phase?
To see if it collapses any further.
Correct. You want to exacerbate the tiny pneumothorax that you can't see. So on expiration, your lung volume reduce. If there's pneumothorax, it's going to reduce further. So you can exacerbate the pneumothorax. Of course, you want erect because you want the air to travel up. Gravity ma. Okay, the air will travel up. Pneumothorax will be at the top. Decubitus tak boleh. Okay, it's difficult to see at the side of the lung. Lots of soft tissue and lots of interference. Can't do that. Okay, PA erect on full expiration. Okay, Hai Liang, you want to show us something?
Yeah, so this is just extra stuff that I think can be quite relevant. So this is the CAT, the COPD assessment test. And then this is the acute exacerbation, like in case of acute respiratory failure in a COPD patient. This is the thing that I think is quite relevant for us. So this is a diagram I copied from Kumar and Clark lah. So is it, do you think this is okay, or do you think should be added something else?
Blood gases. I'm not very good at kilopascal. How much is 8 kilopascal?
I think it should be some less than 60 millimeter mercury. PaCO2 more than 7 is more than.
I hope it's
45.
45.
Yeah, 45. I don't know.
Yeah, lah. Our cutoff point is, hypoxemia is less than 60 and hypercapnia is more than 45, right? Okay. Okay. So for COPD, never aim too high oxygen. Okay. Any PO2 of more than 60 is good enough, or correlate with SpO2 of probably 88 to 92 is good enough, as long as they are comfortable. Okay, if your SpO2 is 90 and patient is obviously tachypnic, of course you can't keep them off SpO2 of 90. Okay, and I agree with this chart. You can give oxygen, all right, but at a controlled rate. So Venturi mask is the best option. Okay, so then you have to reassess the patient, both the O2 and PCO2. So after giving oxygen therapy, like it or not, you have to take a blood gas. It's quite painful, but sometimes we have got no choice. Okay. So you see that there's two ways, okay? O2 increase and CO2 steady. So you know you are doing the right thing, okay? You don't cause CO2 narcosis, and you successfully increase the O2, okay? Then you can gradually reduce your O2 later, your O2 supply later. Okay. So, but if your PO2 increase, but your PCO2 also increase, you're looking at causing more CO2 retention. So this is dangerous. Okay.
Mhm.
So if the pH is still okay, probably you can look into and encourage deep breathing exercise. But if the pH starts to drop, then it's time to offer patient assisted ventilation, whether it's non-invasive or invasive ventilation. That one is probably not your level, but as long as you have the knowledge or kesadaran, in patient with COPD, can't give too much oxygen. If you want to give oxygen, must give at a controlled manner. And if the CO2 starting to go up, it's a danger sign. If you know that, I think you are quite safe. Okay.
Okay.
So just one more last advice to you all. For COPD management, this is probably acute exacerbation. That's going to take another topic. But management of stable COPD, it still go back to the step by step. Number one, confirm whether it's truly COPD. It's diagnosed as hospital Penang. We don't have the lung function test or the chest X-ray. You can repeat in your own center. Repeat the lung function test. Repeat the chest X-ray here. Okay. Once you confirm the diagnosis, if patient on adequate treatment. So we talk about how to upgrade the treatment, right? If patient is on treatment, how is the patient? Continue to exacerbate? Why? Right? Is he still actively smoking? Still exposed to those charcoal, those dust? Or he need other things like pulmonary rehab, upgrading in his inhaler therapy, or other comorbid. Okay, a lot of my COPD patient can say short of breath, we give inhaler, doesn't go off. Rupa-rupanya at the same time got heart failure. All right, they are smokers, they are elderly. So don't forget your IHD, your heart failure, your arrhythmia, DM, hypertension, obesity, OSA. All these things come like a package. Okay, so we have to manage all these things together so that your COPD will be controlled. Okay,
Okay.
anything else?
Any more questions?
I hope you all learned something.
Yeah, I think it's very knowledgeable session we have today.
Yeah, I hope I'm not wasting your time because you all are sitting at home, not coming
No,
in.
no.
Hope
Well,
I can, help at
we
least
hope
a
that
little
we're
bit.
not wasting your time, doctor.
Lah, okay lah. I mean, teaching is part of my. I'm paid to do it, right? If I don't do it, gaji tak berkat.
Okay.
No, I enjoy teaching. I really enjoy teaching. That's why I come to university anyway.
All right.
Hi, doctor. What does ARD? Why does ARDS in COVID-19 have no non-compliance? Very good questions. I'm not too sure. This probably I need to ask my NS colleague. Because the ARDS in COVID-19, to be honest, is very different from ARDS we see from other cause. Okay, so ARDS in COVID-19 is not yet fully understood, and the way they ventilate ARDS in COVID-19 is very different how we ventilate a normal ARDS. So why I don't think anyone has a confirmed proper answer to that, to be honest. Yep.
Okay. So
Okay. If no more questions, I think we can say bye-bye.
yeah, okay. Thank you, doctor, so much for
No
your
problem.
session.
My pleasure.
All right. Okay.
Okay, thank you, Hai Liang, and thank you everyone for attending.
Okay. Thank you, doctor.
Okay, bye.
Bye bye. Okay. Thank you, guys. We'll be taking a break lah for a while. You see my typo so many already. Yeah. I think I'll take a break for this week and probably next week too. See how lah. Okay. Bye, guys. Feedback form. Please fill up. Thanks. Bye.